Thank you for this opportunity. Let us talk about incomplete colonoscopy. Who is at risk and why does it happen? When you see a patient who is tall, thin, and a woman, and if she has any history of pelvic surgery or history of diverticulosis with diverticulitis, that patient is at risk for incomplete colonoscopy. To understand this better, we should spend some time looking at the colon anatomy, dimensions of the colon, and also learn about importance of mesocolon. In an interesting study of incomplete colonoscopies followed by CT colography, the group from Madison has shown us that normal colon is 167 centimeters in length, and in patients who had incomplete colonoscopy, they had a very long and redundant colon extending up to 210 centimeters. In addition, patients who had incomplete colonoscopy also had severe diverticulosis with angulated fixed colon. Where does the endoscope get stuck? Depending upon where the redundancy of the colon is, one may get stuck in the descending colon or in the transverse colon. So, with this background, let us talk about how do we prepare to have a successful outcome starting in the clinic with instructions to the patient who had prior incomplete colonoscopy. It's important to stress the importance of excellent colon prep uh, with a split dose prep, large volume prep. In some patients, you may have to give additional doses. And sharing that information in person instead of leaving it to the nurse does make a difference. Also, you should plan on scheduling your procedure at the end of the day without having to worry about anybody waiting for you after as you're doing this procedure, and a longer time slot, typically 2 to 3 times more than a normal colonoscopy. Coming to the equipment choices, when you want the endoscopy assistant to pick up the endoscope, if you know that the patient has a long redundant colon, you should go with an adult scope. If it is angulated, fixed sigmoid colon, the slimmest scope that is available is better, which has a better angulation angle. Also, make sure that your assistant check the knobs, that the knobs are not too tight as they can destroy your thumb during the difficult colonoscopy. The second one is the assistant should check the tip deflection to make sure there is proper tip deflection so that you can negotiate the angles. If it is not, then you will be struggling and putting the loops more than what you would want. I would like to take a little bit of time to share some other principles of how to use the suction channel. When you apply the suction by pressing on the red button, you create active suction that leads to collapse of the air column just in front of the scope without necessarily shortening the length of the colon. Instead, if you try this technique that I've used in my practice, that is passive venting by removing the biopsy port when I'm struggling to go through the colon, what it does is it shortens the colon and allows you to get to the cecum easily. So, active suction, passive venting, things to keep in mind. There are different ways to instill water, either through water channel, biopsy channel, or by using the air-water channel. Water assisted colonoscopy, either water immersion or water exchange, has revolutionized colonoscopy. A very simple technique with a lot of impact. And this has been shown to be useful in patients who have had failed colonoscopy, reaching a cecal intubation rate of over 96% in patients who have had prior failed colonoscopy with the less exertion from the endoscopist. You could also try this technique that I've been using, water through the biopsy channel. And this is good for cleaning the debris, and you have less issues asking your assistant to backflush. This is how I do. I disconnect the water jet channel, attach a needle, and insert it into the biopsy port. So these are the steps. So if I press on the foot pedal, it cleans the shaft. If I press on the foot pedal and also apply the suction, it cleans the umbilical cord. And if I submerge my scope under the water, under the debris, and suction, it suctions the debris by just suctioning, and it could clog the channel. And if that happens, you press on the foot pedal and the water from the water jet goes through the umbilical cord and clears it. This technique has been found to be very useful, and you should try this to help your patients. Another technique is minimal water insufflation technique, and by pressing on the air water button without using any water, you get a very little amount of water that is sufficient to just open and visualize the lumen, and that allows you to get in without distending the colon. Although not shown to be useful, but I have used this technique in one patient and found it to be successful. When it comes to setting up the procedure, you need to set up uh, in such a way that you would avoid unnecessary injuries related to difficult colonoscopy. Starting with the umbilical cord, if you have a loop, make sure you straighten it to make it easy on your left side of your body. If the bed is low and is in the center of the bed, make sure that you elevate the bed to proper height. And I bring the patient to the edge of the bed to make it easy for me to function without having to struggle. As you go through a redundant sigmoid colon, once you reduce the loop, I try to apply the stiffener once I'm beyond the sigmoid colon. That allows me to go and reach the cecum. Always ask for a great assistant to help you manage a patient with difficult colonoscopy. The principles are: if you create a loop, reduce the loop, then apply the pressure to prevent the loop from reforming, and then that would allow you to reach the cecum easily. If it is a sigmoid loop, you apply in the lower abdomen. If it is a transverse colon loop, you apply in the upper abdomen. I would like you to read this paper by Dr. Jerry Way about how to apply pelvic pressure in a sequential manner, starting in the suprapubic area, left lower quadrant, left loin, and then epigastric area. And these positions allow you to prevent loops in those areas where we tend to form loops a lot. You could also consider the use of abdominal wrap. Here is a collar wrap that is applied at the beginning of the procedure that prevents the loops from forming and allows you to reach the cecum. Less need for assistant to apply pressure. So we talked about concepts of that you could use in any practice without having access to different new techniques. How about if you refer a patient to one of the advanced centers? In addition to these techniques, they can use balloon assisted colonoscopy, either single or double balloon. The balloon allows you to anchor and reduce the loops. And in this study of over 600 patients, largest in assisted colonoscopy, they had excellent results. Sacral intubation rate of over 97% and no complications. Two new devices that you should keep an eye on, and I've used one of them. This is a rigidizing overtube. The overtube is a vacuum actuated stiffener overtube that allows you to reduce the loop, and the overtube stiffened prevents the loop from forming and allows you to reach the cecum easily. In a study, the authors have shown that the work input has been greatly reduced by using the rigidizing overtube. Another new device, we all have used the spiral endoscope spiral device, and this is now available as a spiral endoscope and a motor. This can be used for also patients with failed colonoscopy, and preliminary data shows that uh, this has been successful. When it comes to difficult colonoscopy, there are two types of injuries that you can get into. One is a hockey stick injury. As you try to push your scope, the sigmoid loop keeps on getting worse, and before you realize, on the back end, you created a rupture of the sigmoid colon. And this can happen during insertion, so you should be aware of this, and you should withdraw the scope if you're not progressing forwards. Change to a different technique. You could also get into trouble with a barotrauma, especially if you're navigating through a very fixed sigmoid colon, and the air can distend the cecum and cause rupture. The simple technique to avoid this problem is venting. When you vent, the air and the CO2 gets uh, passively vented out, and less trauma. So, what are the benefits, and why should we do a complete colonoscopy? And Dr. Rex has shown that in a large series of patients, he noted that in patients where he completed the colonoscopy after prior failed colonoscopy, he found adenomas in a large proportion of patients and cancers in up to 2%. And a third of the patients had advanced adenomas. So, in summary, we covered a lot of different aspects, some of the smaller details that are important for a successful colonoscopy. And I would like to take your permission to dedicate this talk to my mentor, Dr. Karnadev Bharadhan. Thank you.